to move into a very insightful and an engaging session where we understand and learn from these real life clinical errors. So leading this session is Ms. Savita Manvel. She's a nursing quality coordinator at Jupiter Hospital, Thane. She has over 19 years of experience across clinical care, infection control, and nurse education. She's also a Six Sigma belt, green belt holder and an active contributor to various nursing conferences and CSR initiatives. Please join me in welcoming Ms. Savita Manvel to take on the session.
Thank you, ma'am, for that warm welcome. And I feel honored and privileged to be being given this opportunity to speak in front of such esteemed leaders of our nursing fraternity. And I'm extremely grateful to Kaho, Annie, and INS for this opportunity given. So before I begin my session, with the permission of the host, may I request our participants to kindly quickly come on the video. Please put on your videos, all the participants.
Participants cannot put on the video.
Cannot put on the video, I think.
Okay, all right. So we'll just have a quick exercise. So those who can come on video, please come on video and we'll have a quick exercise, okay? So participants, we cannot see you, but then there's somebody up who's looking at us, okay? So with sincerity, everybody will just pinch our ears, okay? The ear lobe basically between the index finger and the thumb. So 5 points. So 1, 2, 3, 4, 5. Let's repeat that. 1, 2, 3, 4, and 5. Thank you so much. So this exercise, those who practice yoga, this is basically to enhance our clarity, the mental clarity, to enhance our focus and to enhance the hearing. So that's why we have quickly done this exercise. Now, pinching the ear, we must have experienced in our childhood. When we did a mistake, when we did an error, there must have somebody who must have pinched our ear. So we must have thought it as a punishment. But that was not really a punishment. It was basically like for us to remember what is our mistake and then look at it as a learning opportunity. All right. So being said that, without wasting much of the time, I would like to share my screen. Is it visible?
Yes, it is, Savita.
Yes. Thank you, ma'am. So a quick quote. One missed dose, one wrong label, one assumption, and a patient's life can change forever. While errors are unavoidable, but the important thing is to view the errors as an opportunity for growth and improvement. And for this, learning from the errors is very important. So learning from errors is basically a powerful concept in both professional development and professional growth. It also helps in our personal development. Rather than looking at the errors or rather than making a blame game environment, it is important that we analyze the mistakes to understand what went wrong, why it happened, and how to prevent it in the future. So being said that, now we have been listening to a lot of quality indicators and data. So being a quality professional, we play with a lot of numbers. So let us take a quick look at the statistics and its impact. As per WHO, 1 in 10 patients experience harm during the healthcare. There are 3 million deaths that occur globally each year because of these errors. And the main reason or the cause for these increased medical errors is basically the burnout among our nurses. And the result of these errors is longer hospital stays, disabilities, higher treatment costs, and eroded patient trust. Hence, there is a need for sensitization and proactive error prevention in our nursing practice. So, being said that, let us take a look at what are the common types of errors. Okay. So we have patient identification errors. Now, patient identification errors can happen when you have, like, we are busy and at the same time, if you get multiple admissions, so we may end up either not applying an identification band, or maybe there is a possibility we can apply a wrong ID band. If you have patients at adjacent beds with similar names, at times it can also be similar full names, a patient identification error can happen. If we have failed to identify that a patient is a vulnerable patient, or the patient is having any allergies to any food or drug, and we do not apply the proper ID ban, we can end up into an error. And the common error we see with regards to patient identification is the wrong labeling of sample. Now, over here, what we see, the labeling is done by one person, the sample is collected by the second person, there's a third person who puts the voucher, and a fourth differently person who is sending the samples to the pathology. As we say, too many cooks spoil the broth, ending up into a patient identification error. Next error is communication errors. It could be primarily because of the language barrier. We have healthcare workers, we have patients who are speaking different languages, different culture. We have people from different cities, different states, even different countries, because of which language errors or language barriers can lead into the communication errors. Then also, if we're not passing on the proper critical values are not being reported, or the panic values are not being identified properly, because of which there is a possibility that we may end up on missing on any intervention or treatment for the patient. Communication also, telephonic communications, if there is no clarity in the message, then this communication errors can happen. And the common thing among nurses with regards to communication, it can happen incomplete communication during the handovers. There can be either duplication of a treatment or management, or we can miss upon any treatment or management because of this incomplete handovers. Next is documentation errors. Now, in documentation errors, we could say about not doing real-time documentation or doing any late documentation. The common thing in documentation errors see is the unapproved abbreviation, or the wonderful abbreviations that the nurses, we create these days. Not only nurses, we have seen even with doctors. We are so much used to social media, so much used to that chattings. So that shortcuts or the short words are even seen in our documentation. Example, I thought. What is the spelling? THOUGHT, thought. But because of the chatting and all, we use THOT. So that similar communication or similar it also does reflect in our documentation. So that is the impact, of social media on a documentation errors. Then we have medication errors. Medication errors, very simple. We do not or we are not compliant to the rights of medications. It can lead to medication error. We can administer, the medication errors. It can happen like it's a wrong patient or a wrong drug or a wrong dose administered. Even not observing the side effects that a medicine has, it has occurred, or the drug reaction that has taken place is also a significant form of medication error. Apart from the rights of medication error, we have the error at the time of indenting a medication, maybe with similar names, or the dose or the strength is not proper, or during administering it to the wrong patient, or a wrong drug, or a wrong dose. And documentation. Documentation of medication errors is basically giving a medication or administering a medication, but not documenting, or documenting before administering the medication. These all are few examples we can list down when you talk about medication errors. Coming to clinical judgment or decision-making errors. Now, clinical judgment, we have a protocol called as early warning scores, but which helps us to understand if our patient's condition is improving or worsening. If not followed, we will miss out on the important signs and symptoms which will tell us the patient's condition is deteriorating. If we miss on these symptoms, we will not be in a position to give the appropriate treatment and management. So it does affect our clinical judgment. We will not be in a situation to identify the change in the clinical condition. Then we have equipment related errors. This can happen if there is an improper use of the medical devices that is available with us, or if there is any faulty equipment and there is a failure to report this faulty device about the faulty device. Fall and injury prevention errors. So nurses are primarily responsible for identifying that my patient is at a risk of a fall, a risk of a pressure injury, or any other safety concern. And based on that, we are supposed to provide the safety measures. Like, for example, if the patient is at a risk of fall, putting an ID band, identifying him or her as a vulnerable patient, ensuring the side rail is being made like kept up all the time, ensuring all this fall safety, fall prevention measures are being followed. It is a responsibility of the nurse. But failing to do so, we can end up into a fall or any injury for the patient. Next is ethical or legal violations. This basically happens if the standard of practice is being not followed. Now, over here, we can talk about any breach in the existing protocol or any neglected care. Neglected care, there is a possibility we can find a neglected care in patients whom we have a negative consent. Now, the relatives have given a consent for not doing in any aggressive management. That doesn't mean that the basic care of the patient is also being neglected. It is important that we give them their hygienic needs are met, the nutritional needs are met, the elimination needs are met. They have any signs and symptoms that needs to be addressed. Neglecting such care is an ethical or a legal violation. So these are some of the common types of errors. What could be the causes of these errors? So first is a human factor. So in human factor, we can talk about fatigue. So at times, nurses may have to work in long shifts. They may have to work overtime, the night work, which brings out fatigue in them. Distraction, we are known to be as multitaskers. So while doing this multitasking or while administering the care, if we have been interrupted, that causes a distraction and our focus gets moved out. Stress or burnout. Stress is basically, it can affect our concentration. If we are doing multitasking, we are burned out and we are like, no, under stress. So because of the stress, our concentration or our focus gets shifted. Inexperience could be if we are not aware about a particular protocol, about a particular procedure, about a particular equipment. So that can also lead to an error. Complacency. This is relying too much on the routine or assumptions. The common statements that we could have heard: I thought, I assume, I felt. We have these punch dialogues by our nurses. Whenever you ask them if an error has happened, so what exactly happened or why did that error happen? So we must have heard मुझे लगा, मैंने सोचा, मैंने समझा. So these are some of the common excuses we listen. But then these are the factors which can eventually lead into an error. Next is system or process failures. Understaffing. If we do not have adequate staff, the workload comes on the existing staff. And because of this, they're rushing in to provide the care and meet the task, which is assigned to them. So in this, what happens is like they end up doing some error. As we say, haste makes waste. So when they're rushing to ensure that the care is being completed, they end up into an error. Then we have lack of supervision. Lack of supervision, especially if we have a new staff, a new joinee, it is essential that a proper hand holding is done for them. Their work is supervised, and failing to do so can lead to an error. Inadequate training, again for the new joiner, there has to be a proper induction and orientation training at the time when they join with us. Also, if there is any new process, new procedure, new equipment, trainings need to be provided. Failing to do so can lead to an error. Then faulty processes, if there are no standardized procedures, standardized protocols, or inadequate processes, can lead to an error. Next, we have technological failures, which include malfunctioning. So if we have equipments or we have devices which are not functioning properly, or we are not, there is an incorrect use of these devices, then it can lead to an error. Over reliance. We are so much used to technology, we are so much used to the equipments that we just rely completely on this technology and equipment without doing any double check, and we end up doing an error. Environmental factors, we could say poor lighting or ergonomics. If we do not know how to use a particular device or how to use a particular equipment, we do not have the proper body posture for it, or there is poor lighting which can wherein we are not able to maybe read a label, there is a possibility that we then end up in an error. Noisy or chaotic work setting or disorganized workspaces. If the work environment is noisy, there is a lot of chaos or a panicky situation, it is not organized, there is a lot of distraction such environment can get, bring in. And it is there is a difficulty for the healthcare worker to focus on their task assigned. So these are some of the causes which basically leads to errors. So all being said and done about the errors, the causes and types, we are after all human beings, and to err is human. There's a famous saying which goes, to err is human, but to disclose and learn from these errors is true wisdom. So what we should do is our approach to the error matters. So how should our approach to the error be? It should be productive and not punitive. We have heard from my co-speakers that there should not be an environment of blame game. What should be done? Let us take a look at these steps. So first is implementing a culture of safety. If the healthcare worker of the team member knows that the environment is safe for me to report any error or any mistake without a fear, they are free to disclose that, okay, there is a mistake that has happened from me. This enhances their trust in the organization. Also, it boosts the morale of the team worker. Next is providing adequate training and education. Training and education, basically, it helps us to reinforce the existing processes or protocols, and also it will help us to make the staffs aware about what are the current guidelines or the current trends or the current learnings in our medical field. Also, training is like a win-win situation. It not only ensures the success or the professional growth of the employee, but it also ensures if you have a well-learned employee, a well-satisfied employee, so even the organization eventually feels successful. So it is like a win-win situation for us. Next is utilization of technology. So we have electronic health records. The electronic health record has, if it is a well integrated EHR system, everything about the patient is present in the EHR, which includes the present history, past history, medication history, allergy history. So anytime if we are trying to indent a medication and if the patient is allergic to that medicine, it will give us a pop-up. So an error can be prevented, right? Then we have the barcoding and RFID technology. These technologies are basically very useful for patient identification. So ensuring that we have the correct patient being identified. It helps in preventing medication errors and also the specimen labeling. So these technologies can be used. There are very smart infusion pumps. Now these pumps, they ensure that we are able to administer the infusions or the fluids at a precise timing and a precise dosage. So there is, we are assured that there is no extra dosage or extra fluid going to the patient, nor there is a less amount of fluid or infusion or medication which is being administered to the patient. So that is a benefit. Then we also have various wearable devices which helps in remote monitoring, and also the patients at the comfort of their house or the home itself, the remote monitoring can be done by the consultants or the doctors, and they can advise the medications, the management, or the treatment that is required. So utilizing technology, if you have a good technology and utilizing it in the proper, correct, best way, can help us in preventing these errors. Then implementing standard guidelines and protocols. So if we have standardized guidelines and protocols, it ensures that everybody is on the same page. Also, it ensures that there is uniformity of care across the organization, at least for few of the common procedures and protocols. So that is ensured. And also it ensures that there is systematic care that is being given. Then encouraging patient involvement. Patient plays a vital role in error prevention. For us as healthcare workers, we have to, study all the anatomy, all the systems, anatomy, physiology, understand the various disease condition, pharmacology. But for the patient, he has to just know about his disease condition. And correct me if I'm wrong, the patient has, these days the patients are so smart and so much, even they are used to technology, that they have done literally a PhD, you can say, in their disease condition. So even if we miss on anything for the patient, if there is any minor discrepancy with the patient involvement, they will be in a position to highlight that discrepancy or a miscommunication. Thereby, they can help us in preventing the error. And last and the most important is sustenance. So my previous co-speaker has spoken about sustenance, sustaining. It is easy to initiate a process, a protocol, but ensuring that there is consistency and it is being practiced throughout is a challenge, but it is also essential. So how we can ensure there is sustenance is basically by conducting audits. So we have seen about the different kind of audits. We have prevalence audit, there are retrospective audits, concurrent audits. Now, audits can be decided like few parameters. There are by default, we need to do audits like, basically maybe the handing over tools and all, the compliance, the initial assessment. These are some of the parameters. By default, we need to do the audit. Few audits can be done depending on the errors. Okay, this is one thing for improving the error. To identify the reason if there is an increase in a particular error or a particular incidence. For example, we had incidents wherein there were like D-linings were increased. So when we asked for the cause, it was like patients were restrained, but then they would just pull out the restraint and they would just ending up pulling out their tube. So we thought, why not let's do a restraint audit. So similarly, we can do audits on incidences or errors which are very high in our organization to understand why it has happened and what are the root causes, what are the corrective actions we can take, and how we can prevent it in the future. That is about the audits. Then we can take feedbacks about the processes or protocols which are in place. We can take feedback from our team itself, from our co-workers, colleagues and all. The feedbacks can be taken. And very much important, we must have seen whenever there's a closure given for any a kappa, so the corrective action is reinforced about the protocol and the preventive action is training is done, training will be done. So we are so much into training, right? So training, it should be starting from the day one we have an employee joining us. So it is important that we have an induction and orientation training so that they are well versed with our protocols and policies and processes. Then on job trainings, so when they are at their workplace, so continuous training with in reference to the work or the task that is assigned to them. Then any incidents based training, if any incidents happens in my particular department by one particular staff, I have to ensure that incident, only the incident, not the name of the person, is shared with everyone. So it becomes a learning opportunity for everyone. Then there could be a periodic sensitization of incidents training so that we can showcase what is our quality indicators, the data, as data talks a lot. So we can just showcase like where we stand, where we need to improve or where we need to sustain so that data can be shared. So for sustenance, audits, feedbacks, training is the mantra. So talking about training, we'll talk about learning and development. So which is most cost effective, right? So I've listed few strategies out here. What all strategies we can implement when we have to learn from the errors. So one is simulation of clinical scenarios, okay? So we have Edgar Dale who tells that we remember only 10% of what we see, but almost 90 to 95% of what we practice and train the others. That's the reason simulation based training is very essential. We'll take a look at the benefits of simulation of clinical scenarios in the next slide, upcoming slide. Then constructive feedback. Now, it is very important that when you're giving a feedback, it should be in a positive way. Like, you have expressed your concern, the person has not felt bad, but also whatever was your concern is being addressed to the person who has done the error. It is a powerful tool which, for improving the performance and building stronger relationships. Now, when we are giving a constructive feedback, we first need to talk about what are the positive things, and it is important that the corrections to be given only to that for that particular error or problem that has happened. Never keep at the back of your mind if they have done any errors previously, or there is something which is, we need to have correction for that particular person. Please do not keep all that at the back of the mind. It's always important that we focus at the present situation, the present problem, and give corrections only for that problem. That will ensure the we are giving constructive feedback. Then mentorship. uh, Mentorship is basically a professional relationship in which we have an experienced person who is helping an inexperienced person. So this experienced person, many of us, we may be having mentor-mentee concept or a preceptor-preceptee concept. So wherein the experienced person helps in hand-holding a person who has no experience or who's just new to the organization, so they will help them in developing their skill, developing their competency, understand their job role in a better way. So that's why we can have mentorship. Peer support. Now, when an error happens, it does affect the patient, but it also emotionally has an emotional impact on the person who has conducted or who has done the error. It's never a person who's done the error. It's always somewhere some system or a process failure because of which the errors happen. But then the person gets emotionally burdened because of the error. So making a peer available wherein they feel comfortable to express out and to have a self reflection, like what went wrong, how it went wrong. If they're able to vent it out, it will lower their emotional burden, and then they feel more comfortable and they will bounce back. They'll become more resilient because of the error and the support that is being provided to them. Then debriefing. Debriefing, usually it can be done after any codes. Now we do mock drill for the various emergency codes that we have, but there are also actual code scenarios. So it is essential then and there we do a debriefing of what went right, what went wrong, what could have improved, so that in the next scenario we are more confident and in a more better position to answer that code or respond to that code. Also, debriefing, it can be done after any incident that has occurred, any error that has occurred, or if there is any new protocol that has been set in place. So debriefing plays an important role. And the most important, education on patient safety. Now, while talking about patient safety, there is a complex healthcare environment that we are looking into, and patients are more well versed with the healthcare setup and everything, the hospital and all. So it is important that we focus on just the international patient safety goals. It covers all aspects of patient safety. So ensuring that the team is trained on patient safety plays a is quite adequate enough. So being said that, let us take a quick look about simulation of scenarios. It is basically learning by doing. So why simulation? This learning pyramid itself speaks a lot about it. So on the left side of the pyramid, we see the learning activities. On the right side, we see the learning outcomes. So in the learning activity, 10% of what we read and 20% of what we hear is only remembered by us. And this helps us to define, list, describe, and explain a concept, right? Then we remember 30% of what we see, that is either by viewing images, watching videos, right? We remember 50% of what is seen and heard. This is by attending any exhibitions, seeing any sites, watching any demonstration. Now, this helps us only to demonstrate, apply, or put it into practice, whatever is being learned. What is more important is 70% of what we say and write is being remembered. That is done by participating in hands-on workshop, design collaborative lessons. And this is our focus point. That is the 90% of what they do. When we use simulation-based learning with the use of simulators, models, or sharing an experience, we are in a position to analyze, define, create a learning environment, and evaluate what is being learned. So that is why we focus more on simulation of scenarios, so that over here the nurses are made to simulate the scenarios or recreate the scenarios, which helps us to understand the error or understand the learning in a much better way. So the simulation, it helps us to it gives us a visualization of a real world consequences. So when we give them an actual scenario, so they're really in a position to imagine what could have happened, how it could have happened, that imagination cap is being put on. Then it enables skill development and competency. When we make them do what is to be practiced, so it helps them to get an actual feel of that particular procedure or process, thereby enables their skill development and competency. Then it gives a risk-free learning environment. Now, as it's a learning platform and you're creating a scenario, here they are allowed to make mistake rather than making mistake or error in an actual real scenario, real life experience. Then it also gives a deeper learning and helps us to retention. So as we said over here, 90% of what we do, we are analyzing, we're able to define, create, evaluate. So it gives a lasting impression. And hence, our training, our learning should be simulation based. Now, when we talk about simulation based learning, we can make the staffs like what we practice, every new joiner, even the basic procedures, we are giving them a hands-on training, a skill-based training. So that includes even checking the vital signs, beginning from temperature, also how to give a sponge bath. These are all simulation-based learning that we are giving to our nurses who join us, afresh with us. When you talk about scenarios, we have implemented Moot Code, one of the significant part of my presentation today. So to those who maybe not much aware about Moot Code is an indispensable, basically it is a part of legal education wherein the law students have to enact a courtroom situation, and this helps them to develop for building up their practical skill, confidence, and their personal connections. So it's beneficial majorly for the law students for their skill development, legal knowledge, critical thinking, their public speaking, teamwork, networking, their career advancement, professional recognition, and a real world preparation. Now, we have incorporated Moot Court in our training setup also, one of the best wherein we can give a simulation to our nurses. So how we execute the Moot Court. This Moot Court has become a part of a learning planner. Like for the last year, we had it like every month, we would have one department who would come up with any incident or an error that has taken place in their department, and the team would come and do the execution. And this year it is once in a quarter that we have this Moot Court in our learning planner. Then there is a Moot Court script which we require, which helps us becomes more easy for us to enact. Now for the script, we do not need any proper scripted wordings and all. It can be taken from the real scenarios that we experience. The wordings or the sentences, the punch dialogues can be taken from our teams itself, the dialogues which they use, what happened? Why did this mistake happen? So they say, mujhe laga, maine socha. So just these dialogues also can be like utilized when you prepare your script. Then depict the incident. At times we also try to give them a feel of what exactly the incident happened. So there is a role play of the incident also that is being done. Then we have a enact the courtroom situation. So on the right, if you see over here, we have displayed how we give them the feel of a courtroom. So we'll have an accused, we'll have a victim, we'll have a defense counsel, we'll have a plaintiff counsel, and then we have the war and we have the judge. So that is how we give a real feel of the courtroom scenario. We also display the videos of real life stories and the legal cases which are pertaining to the healthcare. All right. So this is about Moot Court. To give a better idea about Moot Court, I would like to quickly show you a video of what we had enacted at our organization. So just a few scenarios I have listed down on which our team had done a moot court. So there was a case, these are not really happened in our organization, it's just that we have given the minor incidents or a significant impact, a legal impact, so that the girls or the nurses, they understand the consequences. Yeah. So we had done a moot court on a pressure injury which was developed in a post-bariatric surgery patient, because of which there was increase in the length of stay and financial burden on the patient. So they had filed a petition. Then a peripheral line which was inserted into an artery instead of a vein, and there were IV fluids given, drugs given, which led to a limb amputation. Then a knee brace which was not removed prior to an MRI, which led to a dislocation of the knee brace, causing injury to the patient abdomen and internal organ. Then accidental delining of abdominal drain, which resulted in significant blood loss. So the delinings are very common. But because of this small delining also, there can be a major impact. So that is what we had, tried to show. The delining resulted in a significant blood loss, ICU transfer, and increased length of stay and sepsis in the patient. Then we also had a moot court which we had enacted during our International Patient Safety Week, the National Patient Safety Week last year in September, wherein we had emphasized on the international patient safety goals. We had created a scenario wherein there was a wrong sample, wrong reports, wrong treatment given, a patient developed infection, and there was a fall. So these all are the scenarios that we had created, which did have a great impact on our nurses when they understood how this could, legally impact the patient also. All right. So with that, I would just quickly like to play our video. But every video, there has to be a disclaimer. So quickly, let me just read my disclaimer. The following video is a simulated moot court proceeding created for educational purpose only. Any resemblance to real case, persons, or dramatic courtroom shows is purely coincidental and possibly coincidental due to binge watching of legal dramas. No actual laws were harmed during the making of this video. Side effects may include that you may have an urge to take notes. Please do not try this at home, but yes, do try it at your workplace only after watching the entire video. So being said that, let's take a quick look at the video. Please grab some popcorn or some munching if you have along with you. And you go. Good afternoon, everyone. We are here today in the matter of Miss Pratnya versus Hope Multi-Speciality Hospital.
Savita, does this have a visual?
Yes, ma'am. Good afternoon, everyone. We are here today in the matter of Miss Pratnya versus Hope Multi-Speciality Hospital. The case of negligence in care resulting in hospital-acquired pressure injury. Plaintiff counsel, you may proceed with their opening statement. Yes, Your Honor. Your Honor, ladies and gentlemen, we are seeing a case of medical negligence where my client, Ms. Pratnya, was admitted at Hope Multi-Speciality Hospital with pneumonia. But just within 7 days of her hospital stay, she developed a stage care to prevent this injury, wherein the hospital staff failed to do was medical negligence. And we look forward for justice for my client, Ms. Kranti. Thank you. Defense counsel, can you proceed with your statement? Yes, Your Honor. While we sympathize with Ms. Pratnya, we contend that the pressure injury developed because of her comorbidity, not due to negligence. She was elderly, immobile, and having diabetes with multiple comorbidities. Though we had provided all the care which is required for her, our nursing staff had done tirelessly their efforts in preventing her pressure injuries. Still, she developed. So we have submitted all the required documents and the expert opinion affirming such cases developing pressure injuries. Thank you. Related counsel, proceed with the case. Sure, sir. Sure, Your Honor. I would like to call upon my client, Ms. Pratnya. Ms. Pratnya, Dr. Dhinay. So, Ms. Pratnya, can you tell us what exactly had happened with you during your hospital stay? Yes, I was moving too, and I remember lying in the same position for several hours, sometimes over there. I told these nurses that I was in a pain, but they told they were short-staffed. And then I developed this awful flu, which got infected, and I needed more treatment after I left. So, were you explained about the risk of such a pressure injury when you got hospitalized? Oh, I only learned about it after I had. Point to be noted, Your Honor. The excuse given was that the staff, they were short-staffed. My client had complained about the pain, but which was not addressed. Thank you. Dependent counsel? Yes, Your Honor. Ms. Pratnya, do you acknowledge that you are suffering with multiple comorbidities during that time? Yes, I had diabetes and pneumonia. Okay. Did the nursing staff explain to you about the various protocols that has to be followed in preventing pressure injury? Yes, they have explained me everything at a time. I will not remember everything. Okay, but still, as you are having so many comorbidities, were you aware because of your comorbidities you can develop pressure injury? That is what they have told since. Yes, but I believe they could have helped me with. Okay, point to be noted, Your Honor. The client is aware of the comorbidities as well as the risk of developing pressure injury. Thank you, Mr. Your Honor. Your Honor, with your permission, can I call the assigned staff, Ms. Manvel, in front of the court? Permitted. Ms. Manvel. Ms. Manvel, can you please prove to the court that you have given adequate care? Yes, we followed the protocols. We have records showing that she was repositioned frequently. She was also assessed for frequently for any skin breakdown. Okay, so in your professional opinion, you feel all the care was spent to prevent the pressure? Yes, I did my best as possible. Point to be noted, Your Honor. The staff had given adequate care to prevent depression. Later counsel. Sure, Your Honor. So, Ms. Mangal, as you said that there are records of repositioning and all that. So, is it possible that despite all these records, there is a proof that the patient has developed a pressure injury? Yes, but as I said that even the best care cannot prevent all the ulcers. Moreover, I was having 7 assignments. Within that, 3 patients were bedridden. I was running here and there to complete the task assigned to me. Okay, so can we think or can we say that you have done your documentation without giving the care? No, I did the care and only then documented. Yes, but I was having few challenges in completing the assignments, so I could have missed few care parameters. Points to be noted, Your Honor. She was having 7 assignments, out of which 3 patients were bedridden. So there is a possibility she also has agreed that she could have missed on few care parameters. Thank you, Your Honor. Thank you, Ms. Mangal. You can take a seat. Your Honor, now we would like to call upon our expert in wound care, Dr. Archana, who can give us her opinion on this case. With your permission, please go ahead. Dr. Archana, kindly come. So, Dr. Archana, you have gone through the case. So, what is your opinion? Could this pressure injury have been prevented?
Yes, I have studied this case, and what I found is that record shows several gaps in repositioning document. In properly monitoring that we have in multiple hospitals around the city, a stage 3 ulcer is will not occur within 7 days duration. There are set protocols which every alternate hospital follows to prevent such injuries in their care. The best being one of them is asking care parents.
Okay. So, Dr. Archana, can you elaborate more about this asking bundle?
Yes, definitely. Asking is, I will spell it out first. ASSKING. This is the bundle care approach to prevent pressure injuries in patients who are getting admitted in the hospital for prolonged duration. So, A stands for assess. For the risk of getting such injuries. There are multiple factors to it, like age, the condition of the patient, the latest conditions, other considerations like diabetes, where the patient has
Savita, voice is not coming. Just volume.
Yes, what is done usually is based on the patient assessment result, the pressure redistribution matrices are used. So, name few, we have alpha bed available in the market, we have inverse, we have water beds. So, these kind of beds are usually prevent pressure injuries, and there are techniques of redistributing the pressure from the bed, pressure points of the body. So, that is usually called offloading. Next is S. S is the skin infection and the care, wherein the pressure points of the body are assessed regularly at fixed interval. W creams available in the market which are applied to such high risk areas wherein there are chances to develop pressure injuries. Then many hospitals have adopted the periodic assessment and the care, which includes back care. So that is one of this skin recall, and we have to keep the skin dry. Next is K, keep moving. So this is basically positioning of the patient. So I had mentioned about the care clock, wherein patient has to be mobilized. Mobilized as in the position of the patient has to be changed every 2 hours. I stands for incontinence assessment and the care. So these patients who are prolonged bedridden and hospitalized and elderly, they are at high risk of losing the control over the bladder and bowel movement. So we have to have the assessment of these things also, whether there is any involuntary passage of urine and the stools. And if it is there, then we have the adequate precautions has to be taken. N stands for nutrition and hydration. Ensure adequate protein and calorie intake. So here the patient is screened for patient's nutritional status because elderly patients for diabetic, they are on multiple antibiotics. They tend to have the low immunity and hydration also not maintained appropriately. So high protein and high calorie diet is suggested, which has to be assessed at the regular interval and has to be provided to the patient. And last is G. G is for giving information. So in spite of doing all the precautionary measures, following the proper care bundles, if there is no exchange of information from one staff to other, one nurse to doctor, one doctor to doctor, right? So this plays a very important role here, giving information. So we have multiple tools available in hospitals like ISPAS, wherein we mention all these patient findings and the care plan. And that gets communicated to the family member as well and next care assigned staff. So this is very important from the prevention point of view. This is all about the asking care bundle.
So points to be noted, Your Honor, there are such wonderful care bundles available which is very simple to follow. And if it is followed properly, they could have prevented this pressure injury, which they have failed to do so. Thank you, Your Honor.
phase of high risk and having lot of comorbidities, can they develop pressure injuries? Yes, in rare cases it can happen because although we take utmost care not to have such injuries, but because of patient comorbidity and nutritional status, it can happen. But in this case, it is seen that it is pure negligence. This was a short duration of 7 days. Stage 3 pressure ulcer happening is not possible. So, point to be noted, Your Honor. Expert also had said that because of comorbidities, there is chance for developing pressure injury. Oh, please point. Thank you. Thank you, Ms. Archana. Thank you, Ms. Plaintiff counsel, what's your final say on the case?
Well, Your Honor, I would just like to say that my client, Ms. Pragnya, she had placed her trust and hope in Hope Multi-Speciality Hospital, which has been violated. We have seen all these documents and we have heard the expert and all, and it does show that there has been some medical negligence. So we are just seeking justice for my client. Thank you, Your Honor.
Defendant counsel, your final say on the case? Yes, Your Honor. In spite of providing lot of care, and the standard care was also met by my nursing staff, but still because of her complexity, she had developed this pressure injuries. So the expert had conveyed that. So kindly requesting you to give verdict in our favor. Thank you. The court has reviewed the testimony from the plaintiff and the hospital staff. Nursing records documenting repositioning and skin assessments. An expert opinion on the cause and preventability of the pressure ulcer has also been taken. While the hospital presented documentation indicating that repositioning was performed regularly, the court notes discrepancies between the documented care and the plaintiff's personal testimony. Furthermore, the plaintiff's expert, an experienced wound care specialist, testified credibly that the development of a stage 3 pressure injury within a week strongly suggests a lapse in care, especially in a controlled medical environment. The court finds that the hospital did not meet the standard of care and rules in favor of the plaintiff, Ms. Pragnya. Ms. Pragnya should be compensated for future medical care related to wound care management and rehabilitation. The defendant, Hope Multi-Speciality Hospital, is further directed to review its internal care protocols and ensure compliance with standard pressure injury prevention practices. The court is now adjourned.
Thank you all. I hope it was quite interesting and there was some learning. So as this case was basically a patient had developed a pressure injury, which was, the care was missed. So I just remembered that sitting for a longer time and not moving can also, we are in a position to develop pressure injury. So before I could summarize about my video, I request everyone to kindly stand because we are sitting already from 3 o'clock. So please stand, everyone. Let's relieve the pressure. Everyone? Participants, we can't see you, but then yes, please relieve the pressure. Please be seated. Thank you and sorry for that. Okay, so as we have seen in the video, we basically, to summarize, we basically have a plaintiff and a counsel. You have the victim, you have the accused, then you have an advocate for both the sides, and you can have a judge, and you can just create a court scenario. And what we do in this is basically, we also make the others aware of what are the problem, what had happened, and what could be the significant impact of it, what could be the legal implications of even a minutest problem. And we also take this as an opportunity to reinforce on what is our process to prevent that error in future. So this is how we basically sensitize our nurses on any incidences. On this slide, I have listed few landmark healthcare cases, which were a turning point in terms of healthcare. So first is Indian Medical Association versus VP Shanta. So the significance of this is there is a Consumer Protection Act which is established in 1986. But after this case, which was in 1995, even the hospital sector, because we are a service provider, it had come under the Consumer Protection Act in 1995. So that was the significance of this case. Second case is Dr. Lakshman Balkrishna Joshi versus Dr. Trimbak Bapu Godbole. So over here it stated that it is a duty of the doctor to care, in deciding whether to take a case, what treatment to be given, and how to administer the treatment. So that was significance. Also, this next case is Kusum Sharma versus Batra Hospital and Medical Research Center. So over here, it basically tells that medical professionals cannot be held negligent merely because a treatment did succeed. So it's basically kind of in favor of the hospital. That is not necessary that because a treatment didn't succeed, the hospital is negligent and also it's just that, but we need to prove our side. So if we Google, there are many cases that we can find out, and we see that even a simple error has led to a major legal implication. So we just need to be very cautious. How this moot court has helped us, it has helped us to sensitize our nurses on the legal implication of the minute or the simplest error. Even if I stick a wrong label on a wrong ECG, it can lead to a legal implication. So that is what we try to sensitize. Then it has helped us to enhance the awareness across the team about various incidences. Having a big team of nurses, it's not possible, or maybe they would not know, one department would not know what has happened in the other department. So these trainings we take as an opportunity wherein we share what is the incidents, obviously without disclosing about the department and all, but just what is the incident, what went wrong, and how we can prevent it in future. It has helped us to boost our staff confidence. We have got so many good, we have seen how confidently, because the staffs are being made available, to do this, act out the moot court. So it helps them to boost their confidence also in public speaking, getting a more understanding about the error. They do literally learn about what was the error, how to prevent. So that has helped in their growth as well. It has increased accountability and reporting. So even a small error, the staff is so much aware that yes, I should take up the responsibility and accountability for my mistake and report it. There is a transparency in error reporting. It is like one's mistake should be another's learning, so that it has helped. And as we have seen in the video, we had an expert opinion that was taken, so wherein the protocols are like reinforced or revised. So it also helps us to reinforce the protocol. One help that it has helped me is it can also help the others. Those who have had a dream of becoming an advocate. So I basically, before becoming a nurse, wanted to be an advocate, but I'm thankful, which I couldn't. But then I'm thankful to our CNO, Dr. Shine ma'am, whom we'll see in our vote of thanks, who's also our host. So she has brought in this concept of moot court in our organization. So it gives us an opportunity, to even act out like an advocate. So those who have the dream of becoming an advocate, you all can surely please use this moot court in your trainings. So to conclude, learning from medical errors is a critical component for improving patient safety. It is important to foster a culture that encourages reporting and the analysis of error. And by taking a proactive approach to learning from errors, medical professionals can improve patient outcome, reduce healthcare costs, and ultimately save life. So let us learn from the mistakes and move forward. Thank you from my end.
Thank you very much, Savita. That was very, very engaging and pretty insightful. You brought to life some things that we would kind of not talk about usually. So thank you very much for that. And I really think this is a method where we can get our nurses to understand what errors are and how we can probably learn from it, and also what it can lead to in case there is a negligence at all. So thank you very much for that.